So good morning, everyone. My name is Professor Sanjeev this morning on the 22nd of February, and it gives me a great pleasure to introduce the first speaker for this morning's session. He is a colleague of mine in the consultant gastroenterologist and a lecturer in the Department of Medicine. He is unique to many other gastroenterologists in this country because Dr. Chua is one of the few who are interested in the field of functional gastrointestinal disorders. Functional gastrointestinal disorders are a difficult group of diseases to treat because they are often misdiagnosed as other conditions and don't have specific diagnostic tests to confirm their presence. So one of the tests that are often used to diagnose this condition, or rather to exclude other conditions associated with this, are breath tests. And not many physicians are aware of how to use these breath tests in the diagnosis of these gastrointestinal disorders. So today, Dr. Chua is going to educate us on the utility of hydrogen breath tests and its use in the field of gastroenterology. So Dr. Chua Kiwat, over to you.
Okay, thank you very much, Prof, for your kind introduction, and thank you everyone for being here. I'm Dr. Chua. I'm going to talk to you about the utility of hydrogen and methane-based breath tests. As you know, in UMMC, gastroenterology were often associated with doing colonoscopy to look for, to diagnose colon cancer, to resect colonic polyps, to manage upper GI bleed, to do ERCP, to remove stones, to insert stents, and etc. But besides all these intervention, we also provide the service for hydrogen and methane breath tests in UMMC. So basically, the utility of hydrogen and methane-based breath tests is to diagnose small intestinal bacterial overgrowth, to evaluate for carbohydrate malabsorption, mainly lactose and fructose, to test for the oral and fecal transit time. Let's start with a case presentation first. A Madam M, 62-year-old lady with underlying diabetes and hypertension, presented with diarrhea for 6 months, 3 to 5 times of loose stool per day. Her HbA1c is not great, 9%. Medication was only glycoside. Metformin was off 1-2 months ago. However, the symptoms of diarrhea persist. So how are we going to manage this patient? In other words, how to approach a patient with chronic diarrhea? Based on the guidelines for investigation of chronic diarrhea in British Society of Gastroenterology, of course, we have to rule out colon cancer, especially this patient has red flag symptoms as onset of diarrhea after the age of 45. To rule out IBD, inflammatory bowel disease, IBS, one of the common functional GI condition that we see day to day, especially in our gastroenterology clinic. Hyperthyroidism, one of the most common non-GI cause. Celiac disease, however, less common in Malaysia. Of course, medication, especially in diabetic patients, whereby metformin, coffin, and some other medication often cause, outer bowel habit. Of course, in this patient, I did the colonoscopy for her, and it was found to be normal. Blood tests, including thyroid function tests, were normal. Based on this BSG guideline, secondary clinical assessment will include to rule out lactose malabsorption, small intestinal bacterial overgrowth, and these two can be evaluated by using a hydrogen and methane-based breath test. Of course, many other causes should be ruled out, including some chronic infection like HIV or micro and other parasitic infection. So now zoom in into hydrogen and methane breath tests. They are basically a test that to quantify measurement of the breath hydrogen and methane. It's relatively inexpensive, non-invasive, and can be easily done. And it's done in our 6th floor endoscopy unit in Menara Selatan. can be do as a clinic sort of procedure. The principle behind clinical breath testing. So hydrogen and methane are exclusively produced via microbial fermentation in the gut. Gut microbiomes, if in the situation of small intestinal bacterial overgrowth, the microbiome is excessive in the small intestine, and or in the situation of carbohydrate malabsorption, the gut microbiome in the colon readily digests carbohydrates, resulting in production of these gases. So this is the cartoon image. So in normal circumstances, glucose is fully absorbed in the small intestine, whereas lactulose is a non-digestible disaccharide that reach the colon undigested until the colon. So usually after 90 minutes. So in the situation of small intestinal bacterial overgrowth, the solution of glucose or lactulose will be fermented by the small intestine microbes. And with that, they will produce lots of hydrogen and methane that will suggest that the presence of small intestinal bacterial overgrowth. In contrast, fructose and lactose is fully absorbed in the small bowel, whereby in fructose and lactose malabsorption, the breath test, we have to do it a bit longer, prolonged, more than 3 hours compared to small intestinal bacterial overgrowth test, whereby we do the test for only 90 minutes to 2 hours. So the unabsorbed fructose and lactose will be fermented by the colonic microbiomes in the colon. Then the gas will be produced in the colon and absorb. The gut microbiome readily digests the carbohydrate and produce this gas, and then will be diffused into the abdominal venous circulation and transported to the lung, whereby they can be detected in the exhale breath. In small intestinal bacterial overgrowth, just to re-emphasize, we use lactulose or glucose breath test, and we will perform it for over 90 minutes or to over 2 hours. And we have to catch the breath using the special design bag every 15 minutes. Lactulose, we use 10 gram, and glucose, we use 75 gram in solution. In carbohydrate malabsorption, fructose and lactose breath testing should be performed for at least 3 hours for every 30 minutes. The lactose we use is 25 gram, and fructose we use is 25 gram as well. How to prepare patients for breath testing? The antibiotic should be avoided for 4 weeks prior to breath test. If tolerated by the patient, pro-motility drugs and laxatives should be stopped at least 1 week prior to the breath testing. Fermentable foods such as complex carbohydrates should be avoided on the day prior to breath testing. Fasting period prior to the breath testing should be 8 to 12 hours. Smoking should be avoided, and physical activity should be limited during the breath testing. This is to avoid unnecessary, false positive or false negative of the result. Just briefly about the interpretation of the hydrogen and methane breath test. As shown earlier, usually we will do a baseline capture of the breath test and put it into the machine, the gas chromatograph machine. Subsequently, patient will drink the solution, then repeat the breath testing every 15 to 30 minutes, depending on the diagnosis we wanted to rule out, whether it's small intestinal bacterial overgrowth or carbohydrate malabsorption. For a positive test, a rise of more than 20 parts per million ppm hydrogen from baseline. Okay, if you can see the first graph, you can see the baseline was very low, close to 0. Once after 45 minutes, you can see in this graph, the gas hydrogen was rise to, more than 10 and subsequently more than 40 by 90 minutes. So the increment of more than 20 is considered as a positive test. Similarly, for methane level, methane of increment by more than 10 at any point was also considered as a positive test. Back to our case just now, Madam Ed had a glucose hydrogen breath test, which was shown to be positive. The baseline hydrogen level was 33 ppm. Then subsequently, by 45 minutes, the increment of hydrogen level to 77. That's obviously increment more than 20 ppm from baseline. In the methane level, the methane was remain low at 1 to 2. So this patient is positive for hydrogen, small intestinal bacterial overgrowth. Just want to talk briefly about the small intestinal bacterial overgrowth. So small intestinal bacterial overgrowth is characterized by the presence of excessive amount of bacteria within the small intestine, which may result in the constellation of GI symptoms. SIBO has been reported up to 0 to 22%, depending primarily on the type of diagnostic test used on a normal healthy patients. Frequency of SIBO is of course higher in elderly patients. Our body has a perfect mechanism to protect against development of SIBO in a healthy patient, a healthy person, but it may be susceptible to disruption in certain diseases. For example, our gastric acid will prevent the overgrowth of the bacteria. The biliopancreatic secretions have the proteolytic activity to make the environment not suitable for bacterial growth. Intestinal motor activity prevent the stagnation of the bacteria to prevent the growth of the bacteria. Intestinal mucosal integrity have the immunoglobulin to kill the bacteria. Commensal flora will form as a competition to the invasive bacteria to survive. Then ileocecal valve will protect our colonic microbiome from backflow to the small intestine. In certain situations, for example, mechanical cause like small bowel tumor, volvulus, intersuccession, they will cause stagnation, and that was susceptible to bacterial overgrowth. Systemic disease, for example, diabetes, scleroderma, amyloidosis, they will impact the motility of the bowels. They will cause the immunity of the individual susceptible. Motility problem like IBS, pseudo-obstruction, medication like opioids, potent anti-secretory agent like proton pump inhibitor that can suppress the gastric acid. Malabsorptive condition like pancreatic insufficiency, cirrhosis, that may impact the biliopancreatic secretion. Immune-related, obviously, HIV patient, elderly patient as mentioned earlier, and small bowel diverticulosis. What are the clinical features? They'll present with abdominal pain, bloating, gas, distension, flatulence, and diarrhea. In severe cases, steatorrhea, peripheral edema, anemia, weight loss, and deficiency of the fat and water-soluble vitamin, especially vitamin D and B12. In typical MRCP exam or medical exam, they will show a case with increment of the folate level but decrease in the vitamin B12 level. That is typically described in textbook, a condition of small intestinal bacterial overgrowth. Diagnosis and the challenges. So small bowel aspiration and culture is still considered as the gold standard. Usually we will do a deep duodenal or jejunal aspirate. It's not difficult for us to do it, but there are many limitations. For example, there's still no standardized techniques. It's expensive, invasive, not easy to culture, especially even in the distal small bowel, whereby our scopes are difficult to get into that level. In contrast, breath test is recommended as an alternative test comparable to the American College of Gastroenterology guideline or North American consensus to diagnose SIBO. Again, just to re-emphasize, usually we use glucose or lactose hydrogen breath test. The glucose hydrogen breath test, based on the meta-analysis, the sensitivity is 0.54, specificity is 0.83. Lactose breast test also similarly, sensitivity at 0.42 and specificity of 0.71. There are also limitations. The tests are not great. There are also limitations. It's low sensitivity in detecting the distal small intestinal bacterial overgrowth. Whereas if we use like glucose, if we use lactulose, it's poorly digested by small intestines. Of course, we assume that our oral to cecum transit time is about 90 minutes is most of the time. But sometimes certain patients can be much shorter. So it could, the lactulose can be flowed into the colon within 90 minutes. That may produce a false positive results because the lactulose is metabolized by the small microbes in the colon. Certain recommendation on who to do SIBO test by the American College of Gastroenterology guideline, they suggest that patients with IBS, you should consider to do a SIBO test, like a hydrogen breath test. Can consider breath test, hydrogen breath test for symptomatic patients with suspected motility disorder or symptomatic patients with previous history of abdominal surgery. In this meta-analysis, there's a SIBO prevalence in patients with IBS was significantly increased compared to control, especially in the case of IBS diarrhea. Just to briefly show you our own study that was published recently in this journal, we show that actually IBS is one of the common conditions we encounter in our gastroenterology specialist clinic. We have published another paper looking into into a case control study of small intestinal bacterial overgrowth associated with functional GI disorder. We found that actually IBS with diarrhea predominant subtypes are significantly associated with SIBO compared to healthy control, non-FGID control, 24% versus 10%, and it was statistically significant. In another one of our papers that was submitted for publication but not yet accepted, we found that IBS patient with SIBO, they are associated with more severe condition, 36% compared to non-SIBO type of IBS, whereby only 16% of them has severe IBS. The severity are categorized by using a questionnaire, IBS symptom severity scale. And the presence of SIBO was associated with poorer health-related quality of life. The fourth recommendation by the ACG guideline on who to test will be on patients with symptomatic patients with constipation, because it was found that in a systemic review and meta-analysis, a significant association was found between methane on breath test and constipation. Now, I just want to talk about the management of SIBO. We should a few key components that we need to focus on: treatment of the predisposing condition if possible, appropriate antibiotic, and correction of nutrition deficiency if present. So this algorithm shows that if SIBO is present by whatever diagnosis criteria that we have done, we can treat with rifaximin. Then ideally should try to manage the underlying condition that make the patient susceptible to SIBO. Common antibiotics we use is rifaximin at the dose of 400 or 550 TDS. Other antibiotics can be considered, however, less studies and less effective, and possible other problems like augmentin, cipro, doxy, metronidazole, neomycin, norfloxacin, tetracycline, and Bactrim. So back to case Madam M. So treatment, I referred the patient to endocrinologist for optimization of HbA1c in order to treat the predisposing condition. I treat the patient with appropriate antibiotic like rifaximin, 400 mg TDS for 2 weeks. To correct the nutritional deficiency, actually no abnormalities on the investigation. So after 1 month, the GHBT was normal and the symptom improved significantly. and she was optimized on the diabetes by the endocrinologist. Next, briefly about lactose intolerance. Lactose intolerance is defined as symptoms on lactose exposure in individual with lactose malabsorption. So there are many types of lactose intolerance, but the most common one is primary lactose malabsorption due to lactase non-persistence with increasing age, with some point polymorphism. Secondary lactase deficiency can happen in, is usually transient, whereby there's damage to the small intestinal mucosa. For example, infection like rotavirus in infancy, enteropathy like celiac disease, giardiasis, and Crohn's disease. Prevalence of lactose malabsorption is very prominent, mainly in Asia, including in Malaysia, whereby you can see it's almost 90% or even more, the prevalence of lactose malabsorption. Just to briefly inform again regarding the lactose malabsorption. So lactose malabsorption primary type typically caused by lactase downregulation after infancy. Usually when we see our infant, our children able to tolerate milk content, lactose related content much better than adult because of downregulation after infancy due to the lactase non-persistent. In Caucasian, this is the genotype. In Asian, not very clear yet, but there are many studies show different types of gene that was related. In lactase persistence, whereby the lactose can be metabolized in the small bowels and absorbed in the small bowels into glucose and galactose, thereby no symptoms was produced. In those lactase non-persistent or maldigestion, the lactose will persist and go all the way into the colon and will be fermented by the microbiome in the colon and produce the symptom like diarrhea, abdominal pain, and bloating after the consumption of lactose. There we can detect it by using the hydrogen breath test. However, most individuals, despite with lactose malabsorption, can tolerate up to a dose of 12 grams of lactose corresponding to 250 ml of milk. The symptoms will depend on lactose dose. Of course, higher dose will have more symptoms, and whether presence of visceral hypersensitivity in the situation of IBS patients. Symptoms like abdominal pain, bloating, rumbling tummy, and diarrhea after lactose ingestion. Many tests can be done, but the best test and test of choice suggested by this review article is hydrogen breath test because of the various benefit. The indication is, of course, presence of symptoms without evidence of organic disease and with high suspicion of carbohydrate intolerance. Why do we need to do it? Of course, if the facility is not available, actually a patient can trial of, restrict the lactose component. But otherwise, if you have the evidence, then you perhaps can avoid unnecessary dietary restriction and possible negative outcome, like, for example, osteoporosis, because vitamin D and calcium high content in milk. So we can, if presence of documentation of that, we can recommend the elimination of diet and perhaps also supplement the enzyme with lactase. This is the similar diagram. They show that if diagnosis is positive, can try lactose exclusion. If successful, can even continue the diet or enzyme treatment, for example, lactase. This is to show that actually IBS patients have more symptoms of lactose intolerance compared to healthy control. So, however, lactose restriction may not completely improve the symptoms of IBS patient, where in contrast, if patient to introduce a low FODMAP diet, whereby one of it is lactose and also other fermentable disaccharides, monosaccharides will improve the IBS symptom much better, up to 70%. Fructose malabsorption and intolerance, at the moment, it's still not clearly, the clinical utility is still unclear. Rome consensus and British guidelines currently don't recommend the test because patients with normal fructose breath test also improve with fructose restricted diet. So the utility is not very clear at the moment. Oral cecal transit time usually reflect the sum of esophageal, gastric, and small bowel transit. So we use the time between the ingestion of unabsorbable fermentable organic compound at start of the colonic fermentation that suggests and the review by a quantifiable rise of the hydrogen concentration in the expiratory breath can be used to estimate the oral cecal transit time. Usually we use 10 to 20 grams of lactulose in 100 ml of water. Then we will collect the breath sample every 10 to 15 minutes for at least 4 hours, 240 minutes. No, normal oral cecal transit time is about 40 to 170 minutes, which is about 3 hours. So the indication is still not very clear. Maybe in a patient with nausea, vomiting, bloating, visible distension, and other manifestation of SIBO that was unexplained. Still no clear indication yet. Guidelines recommendation were also conflicting. So advantage is non-invasive. However, this advantage is a lot of false positive and false negative. Gold standard still scintigraphy at the moment. So in summary, hydrogen and methane breath test is non-invasive, available in UMMC, and the test can be used to diagnose small intestinal bacterial overgrowth and lactose intolerance. However, the utility of the test to evaluate for fructose malabsorption and oral cecal transit time is still unclear. So with that, I would like to thank you. I would like to thank my gastroenterology and hepatology unit colleagues, head by Professor Sanjeev. Thank you very much for your attention. Happy to accept any question.
Thank you, Dr. Chua, for that excellent run-through. A very extensive lecture, and perhaps for people not familiar with the topic, I think it was very comprehensive. So we start off with one question. There's one question already in the group chat from Prof. Tunkusara, and she wants to know how effective is lactase treatment in lactose intolerance.
All right, thank you, Prof, for the question. Actually, there are some studies that show that it may not be very effective. The absolutely symptom reduction in one of the studies shows that 18% absolute risk reduction was demonstrated. Not very great, especially in IBS patient, whereby lactose restriction or lactase treatment only may not be adequate because more important, they have visceral hypersensitivity. So restriction of other diet may also be important, like a low FODMAP diet. But in patients with absolutely lactose intolerance patient, perhaps can try of lactose restriction. No need to be 100% lactose restriction. Maybe patient can still consume small amount. If they still have persistent symptoms, may consider lactase. However, absolute risk reduction is not that high based on certain studies.
Thank you, Kiwat. So, but I guess there's no harm in patients with diagnosed with lactose intolerance to try some lactase enzyme.
Exactly.
But as you say, I think dietary restriction also is advisable at the same time. Okay, so if I was a clinician seeing patients with chronic GI symptoms, I know you went through that algorithm just now from the British Society guidelines. Could you just remind us again, what kind of symptoms would make you suspect somebody to have small intestinal bacterial overgrowth or lactose intolerance, and hence needing a hydrogen breath test? Just to remind the audience again, please.
All right. So the most common symptoms of small intestinal bacterial overgrowth is bloating. In fact, based on certain guidelines. But of course, there are many other associated symptoms like diarrhea, abdominal pain, and many others. In severe cases, even malnutrition. However, these symptoms are very similar in so many GI conditions. So obviously, we have to rule out the organic GI disease, mainly colon cancer, because colon cancer is #1 cancer for male, #2 for female, and many other common GI diseases before we can embark on the test for hydrogen breath test to diagnose SIBO. For lactose intolerance, obviously, it's common in Asian population due to the lactose non-persistence. However, also we need to rule out all the organic disease. And if the patient has symptoms of lactose intolerance, symptoms of diarrhea, abdominal pain, or bloating after the ingestion of lactose, then high suspicion of lactose intolerance, then at that point, we may consider the test of lactose breath test.
Thank you very much, Dr. Chua. I think we've run out of time. I'm sure there may be other questions, so perhaps that can be dealt with later. I would welcome all of you, if you have any more burning questions, to contact Dr. Chua directly. He is a member of staff at the Department of Medicine, and can be contacted via email. So I'd like to hand over to my chairperson for the next half of this session, Professor Azlina from the Department of Molecular Medicine. Over to you, Professor Azlina.